even the best decision-making algorithm is not going to catch all the melanomas. There are going to be clue-poor melanomas. So learning as a doctor the natural history of a mole versus a melanoma, knowing that moles don't normally turn up out of the blue after about age 40. So if your patient just tells you a story about a new mole turning up and they're 60, that's a melanoma until proven otherwise. It kind of doesn't really matter what it looks like. You can go, I don't like that story. Some melanomas just sound like melanomas. So test them. You might think, but I don't want to give the patient a scar. Well, you don't want to leave a melanoma on them either. So all you can do to sort of resolve that is become very good and very efficient at doing small, neat biopsies, so that you're not at least constrained from making the right decision by a lack of confidence about a good quality scar. You can honestly say to the patient, look, it'll take 2 or 3 minutes. We'll get an answer. We'll call you next week, tell you what it was, and then it's put to bed, all right? We'll get an answer, because the reason patients come to get skin checks is they actually fundamentally want certainty. That's why they're paying money to us. They want to know what's on their body. And if there is doubt, we have to find a way of resolving that doubt. And certainty is provided by diagnostic confidence. You can say, look, here's why I think this is not a cancer. But if you've got some doubt, get good at doing quick biopsies, because that'll provide a piece of paper to the patient which says, this is what this is. That's our job. So one way of getting better at finding which ones to cut out and which ones to leave on the patient is, and we teach this quite early in the courses at Health Cert, is look at everything that ever comes across your desk with a dermatoscope. If you can have a look at all the normal moles, have a look at seb-Ks, have a look at warts, have a look at anything, have a look at hemangiomas, have a look at dermatofibromas, have a look at blue nevi, look at everything you can think of with a dermatoscope, so that you just get experience in the normal. Because what we do as skin cancer doctors is a combination of pattern recognition and then pattern analysis. So if you recognize what it is, well, that's what it is. If you don't recognize what it is, you have to put it through an algorithm, a decision-making algorithm. So to get good at the first part, look at everything. Time will make you better. To get better at the second part, apply that diagnostic decision-making algorithm as often as possible and feed back into your own knowledge base as you do it. So once, and this is where having an imaging system might help, just from a self-auditing point of view, look at that picture that came back as not melanoma and look at the report and think, why did I cut that out when it came back as not a melanoma? And your own sort of benchmark for what you biopsy will change with time as you get more experience and you biopsy more things. And you'll get to the point where you actually trust yourself perhaps more than the pathologist reporting the spot as not melanoma. So you can actually find melanomas by just being assertive with the pathologist. If you say, no, I'm reading your report saying this is not a melanoma, but look, it has to be a melanoma. Look at this photo. Listen to this story. They've already had a melanoma. How is this not a melanoma? Could you please do deeper levels or maybe some special stains just so we can all sleep at night? And we're all going to find a few melanomas that way, because as the pathologists like saying, histopathology is not the gold standard. What the gold standard is a collaboration between the doctor and the pathologist to make a decision on what the spot is.